Next speaker is Dr. Susanna Cohen, who is an associate professor and full scope midwife in the Department of Obstetrics and Gynecology at the University of Utah. She is a leader in the field of high fidelity interprofessional simulation, and she is a principal investigator for the LIFT Simulation Design Lab, which uses experiential learning to elevate conversations, improve team communication, and create system change that centers equitable care. Susanna is also the co-founder of Pronto International and designs curriculum, trains master facilitators, and evaluates outcomes of obstetric and neonatal simulation emergency training programs across the globe with major products everywhere in all the places you want to visit: Mexico, Kenya, India, and Tanzania. And she lives in Salt Lake with her partner, 2 children, 1 dog, and 11 chickens.
We only have 9 chickens now. Life cycle. Thanks for having me today, and I'm really excited to be part of this group with many friends and colleagues here. I don't have anything to disclose. Most of this is foundation funding, except I am on the board of Pronto International. So everybody has a story. I'm going to tell you one of mine. We all have many stories. So I'll take you back to 2004, San Francisco General Hospital. I was a midwifery student. This was my first shift on the ward. And I had been a doula before, which is a non-medical birth partner, and seen a couple of births. We were taking care of a woman. Her name was Maria. This was her first pregnancy. And she was actively laboring. The midwife, who was my preceptor, checked her, found her to be 6 centimeters, so in active labor, but probably pretty far from having her baby. So the midwife said to me, you know how to be a doula. You can be here, stay with her, give her support. I'm going to go check on other people and I'll come back. So I did what I knew how to do, which is I brought her to the edge of the bed, raised the bed up, had her lean over so I could rub her back. And then one contraction later, she said, I can't close my legs. So I don't know how to catch a baby, but I do know that if a woman says that she can't close her legs, it probably is because there's something preventing her from doing that, which most likely will be a baby's head. So I look down and I see a black spot, and then I stand up and I try to lower the bed as fast as I can. And then I make a really critical mistake. I turn my back, I walk to the door of the room to find some support. And I look out and I say as calmly as I possibly can, I think she's crowning. And then I turn back in, and I don't know what I saw, but I leaped into the air and slid under the bed and caught the baby's head 2 inches from the ground with the sheet. And the preceptor, who was at the table outside, came in casually, didn't survey the scene, and said, don't forget your gloves. And I looked at the baby's head in my hands and said, well, it was a little too late for that. And then 1 second later, this baby's body slipped out. I caught it before it hit the ground, and we all started laughing. Brought the baby up to Maria, lowered the bed, and she said, I would cry, but I just can't stop laughing. So all's well that ends well. And I actually did see Maria 6 months later, and we just locked eyes and just started laughing because it was really an incredible moment. And I never wanted to go back to the hospital ever again because I learned later in not so educational terms that I made critical mistakes, that I could have called for help, just said the baby's coming. I could have asked the partner to go get help. I could have even pulled the emergency cord from the wall and gotten everyone to run in, but I didn't know any of those things. And I never got a chance to figure those out. And so that really caused a lot of conflict for me and potentially a real critical mistake. So that's my story. And one of them. And I tell it because it really does inform the trajectory of the rest of my career. So the rest of my career, what it has been for the last 15 years, looking at, well, I guess almost 19 at this point, looking at how do we build capacity among our fellow providers and our students to feel confident and capable in the face of emergency. And we do that through simulation. And so I'm going to talk a little bit about that. But what I want to focus on today is that the narrative, the way in which we live matters. And we need to hear those stories, and our work should reflect those stories. So in increasing narratives, we are able to shape our perspectives, generate empathy for another person. We can both get more emotionally in depth with people and understand context, and also create human connection. So I'm going to talk a little bit quickly about how I've used narrative and our teams have used narrative over the last 15 years in capacity building for pre-service and in-service provider teams, in patient care, and then also in research dissemination. So let's start with human-centered simulation. So like I said, here I was, a student, I'm never going back because I didn't practice in simulation. And this was happening before simulation was a thing. And many of you are students now think that there was never a life before simulation, but there was. And so one of the things that we've been doing in our lab, and Gabby's here today with us, is what we call the participatory design process. So human-centered simulation design. So we need to understand, before we create educational experiences for people, what is the lived experience of the patient, of the provider, and of the team. And we do that by focus groups, individual interviews, observations, and then we participate with this, we engage with the stakeholders in co-design of simulations. Because in order to make this simulation and the educational experience meaningful for the providers, it has to reflect their reality. The point of simulation is that you get to practice emergency response or response as a team inside the actual feelings that you have when these things happen. So that when you have the actual event happen to you in real life, you're able to respond and be triggered by all the emotions at the same time. So what this participatory design process ends up looking like is that simulations on postpartum hemorrhage, for example, look very different depending on the context in which the providers, the patients, and the system and the system. So here's one in Mexico. Here's that same simulation during COVID in Utah with a group of midwifery students. Okay, so same thing, but it looks contextually very different. Here it is when we're trying to focus on other topics like caring for women living with HIV in Tanzania and looking at stigma of care. Here's what it looks like in Moab when we're talking about transfer of a woman who's hemorrhaging from a home birth practice into the hospital in a rural state, in a rural area. So, and then this is what it looks like in India. So our biggest project that we've done in the last 10 years is a project in Bihar, India. And what we noticed in all of this is our goal is that simulation should be accessible to everyone, and that we think it's a powerful learning strategy and it shouldn't be limited by your resources. So through a variety of cascading interventions, we started a program in Bihar, India. So fast forward 4 years into the project, we had trained over 1,300 frontline nurses to become simulation educators. So we first train them in simulation as participants, and then we train them how to teach other folks to using simulation in their own facilities, right? This is about creating sustainable models of education. So they had done simulations in 320 facilities. They had trained themselves over 7,000 staff nurses, and we think probably did about 5,000 simulations, although we lost track. We recorded the simulations, we observed the simulations, we recorded their debriefs, we coded them, we watched them, we did WhatsApp groups, we did check-ins with them. We really wanted to learn what was their experience of being an educator, both in their own system and using simulation. And as you can imagine, many things started to bubble up of things that maybe were reflective of challenges or barriers that they may have. We listened to their narrative, and their narrative told us that they wanted to be more connected with each other. They wanted to have increased exposure to how to improve their skills as educators. And so we came up with SuperDivya. Now, SuperDivya is a super facilitator, right? And she has a magical tool set of tools that will help her be a better educator. She has empathy goggles, so she can empathize with her learners. She has a curiosity antenna, which reminds her to ask open-ended questions. She's got a facilitator spray that allows her to have a reflection on what she's feeling that day and how that's affecting the learning that she's having with others. She has a learning lens that helps her focus during the simulation into the real critical learning objectives of that simulation. And she's using all of these tools to combat the evil Professor Agni, who is sending bugs to infect the simulation. These bugs infect the learners and the facilitators. Infects the facilitators with, oh my gosh, I don't have enough time, I gotta skip this. Oh my gosh, I'm fearful. I am really flustered because I was late to work. Whatever my reality is, that reflects the reality of the actual trainers. And then also things that affect the learners. They're disinterested, they're defensive, all of these things that make teaching others challenging. And Superdivia also happened in a moment where we had to change to reflect the reality again. So Superdivia is 10 modules, and some of them occurred during COVID. And so the reflection is, how do you debrief when everybody's got masks on, right? So this idea of how you constantly are looking at the narrative that's happening in the place you're working to reflect it in the work that you're doing. But I shouldn't tell you, I should let Superdivia tell you about herself. So let's see if this works. Do we have sound? We don't have sound. We didn't think this. Anyway, she's really cute. She's telling you that she's here to fight evil and that she wants you to join her on this journey to become an expert facilitator. And you too can learn how to defeat the evil forces against simulation and bring learning to everybody. So here she is. These are all of her tools. So of course, we wanted to know how this landed. So we did focus groups, we did surveys, we did individual interviews. And what folks were saying was that they appreciated that it reflected their reality, right? That she was cool and that it really felt like that she was talking to them. So using using narrative also has helped us here in the US. So tell you a little bit about a project called Project Arise. And again, like they talked this morning, it's really good to have good titles for your projects. So Project Arise was funded by the Josiah Macy Jr. Foundation. And it was really to train interprofessional students and providers in how to have clinical empathy, recognize and repair racial bias and microaggressions in healthcare. And what we really wanted to do is center the narrative of folks in Utah who have had been pregnant or had a baby and suffered from racial disparities. So we hosted a series of community advisory board meetings and story circles to hear the stories of folks here to get their narratives. And then they met with a narrative strategist and a documentarian, and they created 4 mini documentaries. And actually, we just got notice today that it's going to be presented at the FIGO conference in Paris. So we're really excited about that. So what we used these narratives for was not only did the storytellers come to our sessions, but also we watched their stories, and then we practice as students and providers on how do you respond with empathy to these patients? How do you encourage patients to tell their stories within your clinical encounter with them so that their narrative becomes part of their care? And the other thing we did in this project was have simulation again, but this time the simulation was generated by the participant. We called it Simprov because it's kind of simulation plus improv put together. But the idea is that you yourself have experiences of microaggressions and cultural ruptures, and how do we take those experiences, learn to communicate and call folks in and have dialogue with folks that have hurt us in the past and have hurt other people we know in order to repair relationships. And so Simprov has various steps, but the point is that you take your own narrative and then you create a simulation with it, and then together you with your colleagues work through the repair process together. And again, what people are saying is that I felt heard and I felt seen, and I felt that my story was important. And I still, because of that, I was able to learn this next set of skills. So one of the things that came out of this Project Arise was a project by Christy Creel, who was a graduate student during the project, but now she's faculty here at the College of Nursing. And her project was to say, okay, one of the things we talked about in the Project Arise is how do you ask questions of patients to get at their narrative, right? So often we have a list of things we want to go through. We got to get through our differential diagnosis, and we forget to ask questions that encourage the narrative of our patients. And she really feels that narrative is sort of central to creating real effective therapeutic relationships. So as part of her project, she had every single person in our 22-person midwifery faculty practice ask this question of every new obstetric patient, every postpartum patient, and every time we saw an annual exam. And we asked this question: do you feel like your race, ethnicity, or the color of your skin has affected your healthcare today or in the past? And then we listened, we validated, and we responded with clinical empathy. And what we heard was many people said no because of where we live, and said no, but thanks for bringing that up because I haven't really thought about that. And some people said yes. And when they said yes, then we were able to listen to them, validate their narrative, and also meet them and provide really person-centered care and be on the lookout for repeated problems. So the last thing I want to say is, we all know that the currency of academia is presentations, is writing papers, but we may also want to consider how do we use narrative in the dissemination of our research results. So one of the projects we did in Kenya was to interview midwives to understand through qualitative research, what is the experience of providing care in really resource low settings with medication stockouts and salary problems and low staffing and high patient load. And we listened to their stories. And then we had the opportunity to present this at a international conference, but instead of just presenting the qualitative data, we dramatized it. So we had a local dramaturg take the actual words of the midwives, make a script, and we hired local actresses in Canada to perform this, and we just listened to their stories. So we used their narrative that we had gathered in the qualitative data, but we focused on them, on their narrative, instead of just writing it as a paper or doing a presentation. So I guess my question to you is, how can you, in your work, center the narratives of folks, either the providers, the patients, or your colleagues? So of course, this work is the result of many, many years of intense collaboration across the country and the globe. And so we couldn't have done it without all of these folks. So thank you.
Comments, questions? Anyone mind? Okay. Pretty awesome. Yeah. Okay. Oh.
A question about so how do you correct if there is a misinterpretation or not the appropriate empathy? And given that empathy sometimes is culturally taught, how do you navigate around just different cultures and their understanding of empathy? Being in India versus being in Kenya versus being here in the US. So how do you put cultural context to empathy training?
Yeah, so I think the general underpinnings of all of our training is that we want to provide opportunities for folks in the training to have a shared experience, and that the experts are actually in the room. So very rarely do we come at any of our trainings with didactic sessions. We might have a very short, hey, let me tell you about this, or what do you think about this? But really these are facilitated discussions, which is why we call SuperDiv a super facilitator, because the idea is that the experts of their context are in the room. And our job is to create an experience that reflects enough of their reality that and then the courageous space for them to talk and dialogue through how they want to deal with it within their own setting. So you're right. These things look very different all over the world, and certainly not me or any of our team to say how it should look in any particular place. But those people who live there can say how they want their situations to be. And one of the major things about our simulations, which you saw, is that we are using an actual human as our simulator. So we have a hybrid simulator that's like a pair of pants that were recycled scrubs from the laundry. And the patient actress wears them. And most of the time that patient actress is actually a team member. And so the experience of feeling what it's like to receive care in your own clinical setting with your own team, and then having an opportunity to debrief that and reflect on that experience starts to have a discussion very clearly about empathy and quality of care. I don't know if that answered the question. Yeah.